My disclaimer is there is no financial disclosure for this talk. There are so many controversies in diabetes, as we know, and they are to be debated. And then there are so many consensus statements also. You know that how many controversies are there in diabetes, and that's the reason there is a separate one international conference only on controversies in diabetes. That is CODI, and now they also started not only CODI China, CODI Asia, CODI South America, CODI Europe. So there are multiple conferences only on controversies. Primarily, we are focusing on controversies in diabetes treatment. So as there may be more controversies related to diabetes, hypertension, diabetes, lipids, cardiovascular disease, so I am not touching upon. This talk is not for specialists, those who are practicing diabetes specialists. Mainly it is for primary care physicians who get confused and we get more and more about talk about controversies. The controversy in diabetes management, because it's a complex disease, diabetes itself, it is easy to diagnose. We have a diagnostic criteria which are very easy, but it is difficult to manage. There are numerous options to manage with lots of controversies, but still very difficult to achieve tight glycemic control. So we have to be either glucose-centric or we must have a individualized approach to have less and less controversy. The major controversy which I am going to talk in almost 10 to 11, which is management of pre-diabetes, what to do, the controversy in diet therapy. The first on metformin always in debate, and then we will have a debate immediately after this talk. Then what should be the first choice of the therapy? The parglucazole controversy, the uses of alpha glucosidase inhibitor, it is always an issue for its efficacy, so it's become a controversial issue. The role of quadruple therapy or more OAD than 5 or 6 OAD in the same patients, that's a controversial issue. Uses of insulin as a first-line therapy. When to start insulin, how to start, by which way, that's a controversy. Place of GLP-1, whether it should be before starting insulin, it should be after the insulin, or it should be simultaneously. The use of pioglitazone and sulfonylurea along with insulin, and the last is uses of oral hypoglycemic agent in gestational diabetes. So we have divided, and my major controversial content will be on these 12 aspects. The management of pre-diabetes. First of all, whether to treat it pharmacological or only with lifestyle modification, that itself is a controversy. If by medicine, if I want to treat the pre-diabetes, by which medicine, what are the data to support metformin, pioglitazone, acarbose, or ACI, or orlistate, or whether newer drugs also can be useful for the patients who treat with pre-diabetes, that is like DPP-4 inhibitor, SGLT2, or GLP-1 analog. If you see the diabetes prevention program, a study was there where it was compared with lifestyle modification with metformin, and what they found that 50% of lifestyle participants achieved the 7% weight loss at week 24. But at the same time, if you see the diabetes prevention program, you will find that with the lifestyle modification which is better than the metformin. But at the same time, you don't forget that only 38% of the person could achieve the goal at the study end, and that is only they can achieve the lifestyle modification. The intervention was extremely effective, there is no doubt about it, and lifestyle was better than compared to the medicine for the metformin. But we don't know what we should use. Like there are multiple intervention studies on the prevention of type 2 diabetes, where they have used diet and exercise, they have used metformin, glitazone, or even ACI also, and the relative risk reduction you can see the highest was with glitazone, where it was used as a drug to be prevented for diabetes for almost 50%, which comes to equivalent, almost equivalent for diet and exercise, which is lifestyle modification. So then for a physician, he become more confused whether to tell only lifestyle modification or to talk about these drugs also. But at the same time, many of these drugs are not approved to be used in pre-diabetes condition also. Which drugs to be used? There are some trials also with orlistate also, and almost all drugs have shown some benefit for a prevention of pre-diabetes to the diabetes also. So whether to treat these pre-diabetes with multiple drugs other than metformin, they have used even the glycoside, and even the orlistate studies also there. So in meta-analysis they show that many of these drugs can be used in patients with pre-diabetes, but these are the only clinical trials. They are not approved for the pre-diabetes treatment. This is one of the interesting stories with the reduction in the patient's income compared to the patients who are on placebo. There is a significant difference as far as diabetes prevention is concerned. So whether to use or not, that's always a confusion for the doctor. As compared with placebo, pure glucose had shown the conversion of IGT to type 2 diabetes 72%, which is even higher than the lifestyle modification. So I mean, now you can see a glitazone is a molecule which was higher than even the lifestyle modification also for the diabetes prevention. Are there any prevention trials are going on for newer drugs like DPP4, GLP-1 analog, SGLT2? Yes, there are trials are going on, and some data are there to show you also that newer drugs also can be used for prevention of type 2 diabetes also. At present, the ACE guideline is talking about the pre-diabetes management. If the person is having a pre-diabetes and there are 4 criteria, only 1 criteria is there. It means if you have more than 2 criteria, the fasting is also higher than 110 and postprandial is also more than 140. If they have 2 criteria, then you can use glitazone, but use of glitazone is cautious. Otherwise, GLP-1 also written as for prevention of diabetes. For a low risk medication, it is the metformin and acarbose. This is for the American Association of Clinical Endocrinology guideline for a pre-diabetes management. For India, we don't have any guideline for managing the pre-diabetes, but it is always a controversial issue. Even for our patients, when we negotiate to the patient for treatment of a pre-diabetes, they always talk that they will able to do it with lifestyle modification. At the same time, we also have a data to show that lifestyle modification does better. Almost more than 50%, 58% of the patients there was prevention in compared to metformin. And recently, Ramchandran had done a study where he had used the combination of metformin along with lifestyle modification for a better prevention of type 2 diabetes from pre-diabetes to this. Then the second big controversy about the nutrition therapy. The nutrition therapy dietary management of type 2 diabetes changed in last 30 years. Significant change had happened because before 30 years, they used to talk about the food pyramid. The pyramid shape, they used to tell that the lowermost part of the pyramid you can use as much as possible, and the uppermost part of the pyramid you have to use the smallest amount of these things, which is carbohydrate or sugary item, or they could be the fat. But then it gets changed to the plate method. Plate method when comes to know you cannot have everything, whatever the quantity which you want. There has to be a limitation. Whatever you are eating, half of it should be the fiber or a complex carbohydrate, and the other is proteins and the dairy products. So that's the plate method right now. And then pattern method right now, that either you go for a Mediterranean diet or some different type of diet plans which are being prescribed by the nutritionist. So a primary care physician and physician always get confused what type of dietary therapy a person should be given, and that is a big controversy. At the same time, if we see the carbohydrate, how much carbohydrate is to be taken by the patient, because we Indians are almost taking 65% of the diet or more than that by the carbs only. And then again, how much carbohydrates can be taken in the breakfast, because as we know that post-breakfast hyperglycemia is a major problem. If you see again more problem related to the fat, that's a very big controversial issue, because then again, what type of percentages of fat, what type of fat, saturated, monounsaturated, polyunsaturated, again BUFA, then combination, omega-3, omega-6. So for a physician, it's real confusing. And then proteins, and then low calorie sweetener, and then there are different dietitians and different nutritionists. They promote their different weight management plan and diabetes management plans, which confuses physicians more, and this leads to more and more controversy. This is very interesting slide, because we started working that actually in the breakfast we should try to decrease or reduce as much as carbohydrate as possible, because if you know, if somebody is taking even a small amount of the carbohydrate in the breakfast, you will find the post-breakfast peak is higher, even in the normal person or in the diabetic patient also. And at whatever level of HbA1c, you can see here the patient with HbA1c even less than 6.5 or even 6.5 to 7 is we consider is best control, but still you can see the post-breakfast peak is the highest. So I mean, it is the best way to reduce the carbohydrate content in the breakfast, but we have a belief that one must eat diet or the breakfast like a king, and there's the reason many of our patients they take heavy breakfast, and there's a big confusion for many of our physicians what they should suggest to these persons. The low carbohydrate diets, which are also very popular. Recently there is a Atkins diet or a ketogenic diet, which is we are talking about the very low carbohydrate diet, which is actually not promoted in diabetic patients, but still many of the nutritionists they talk about the sentence that will kill all these diet and this will PUFA, and there are also diets for the weight management as well as for the diabetes management. There are diets which are based on the glycemic index, and that's a big confusion for the physician because the glycemic index of each and every food item is not known to them. They don't know when it is used in combination what happens to the glycemic index of that particular plate which they are using in combination different type of foods or different type of bread when they are eating simultaneously, and pasta and pizza and all those things. So that leads to the glycemic index. So diet based on glycemic index, again it's a confusion for that. There are very low calorie diet because there is a paper which had come that very low calorie diet when it is given for 800 to 1000 kilocalorie, given for a 12 weeks, 8 to 12 weeks, there was this some reversal of diabetes, some decrease in the sugar level, and today there was also talk on the Shilpa Rishi had given regarding that whether PLCD can be used instead of bariatric surgery for reversal of sugar also. And then there are multiple other diets which are also in the meta-analysis. You can see there are multiple diets and they have been researched and there are papers to show that they had shown some change in the hemoglobin A1C. So this diet used by a physician is always remaining confusion and that's a controversial issue. The third very important, what should be the first add-on metformin? It always a debate. So I mean, after your pre-diabetes and dietary counseling, now we know that metformin is universally accepted as the first choice of the therapy. Even we don't have much data about it, but still we have that all the guidelines and all world experts, authorities, they talk that it should be the first choice. But what should be the after metformin? Or should we start only with metformin? Now we know that it should not be only sequential. Should we use the combination of therapy? Should we start with the patients not with metformin, rather straight with 2 or 3 drugs? We have the American Association Clinical Endocrine Guideline also that you can start along with what is the initial HbA1c. Accordingly, you can start, but that's again confusion. What combinations they should start? Add-on therapy should be dependent only on HbA1c because what mostly the ASH or American Diabetes Association guidelines they talk about the HbA1c. If you have a HbA1c more than 7.5, more than 8, 8.5, 9, accordingly you can add on therapy, but you may have a patients where the fasting is normal and postprandial is very, very high. That situation may happen in many of our Indian patients. They may have 100 or 110 fasting and the postprandial is 220. Should they combine with the 2 or 3 drugs? We don't know. So that's a controversy. When metformin is contraindicated, when it is not tolerated, what should be the first drug of the choice? All the companies, all the molecules they are talking when metformin cannot be used, that can be used as the first choice. Also the therapy, but we don't have much data for that. And the second and third anti-diabetic agent which should be add-on of metformin depends on multiple factors, and multiple factors are here physicians as well as patient perspective. We will be having a debate that GLP-1 and SGLT2 which should be add-on that, but all the molecules if you just go through, they all have advantage and disadvantage. And what IDEC algorithm is talking about, these second therapy should depend on efficacy, hypo risk, weight, side effects, and cost. But they are talking only of efficacy, it means only for HbA1c, but they are not talking about the glycemic pattern. Because I just give an example, like 2 patients with a similar HbA1c of 7.5. We all know that any medicine will reduce HbA1c by 1. So like you have 2 different type of patients, both have HbA1c of 7.5. Any medicine you use as a second line therapy, I'm sure it may reduce the further HbA1c by 1. But you don't know the glycemic pattern, and that American Diabetes Association is not talking about what is the pattern. If the fasting sugar is normal and only the PPC is high, the things will be different. Or if the fasting and PPC are near normal, then you can start something else. I mean, that is also very important in Indian situation. So what is the glycemic pattern of that patient, and that accordingly we should try to use the second drug. Should we start with like a differential algorithm? Should we not think of only one drug at a time? Should we start combining 2-3 drugs even at the time of diagnosis? Because what we had lifestyle and triple combination was a paper with a few liters of metformin and GLP receptor agonist and try to achieve normoglycemia, try to achieve HbA1c as low as possible, below 6.5 or even below 6, without getting hypoglycemia, but at the same time it will also decrease the weight. So should we use this type of pathophysiological based algorithm or a sequential therapy? That's again a debatable issue, and that's also a controversy which most of the physicians think of. The glycemic control algorithm for American Association of Clinical Endocrinology, they start thinking about the anti-HbA1c, but that is only anti-HbA1c for the newly diagnosed diabetes. But suppose some patient will not be talking much about it. It was in 1999. India is also one of the leading country where type 2 diabetic patients are highest treated with glitazone, and urinary bladder cancer and hence glitazone was suspended in India also for some period of time in June 2013. There is lots of debate about benefit and risk ratio of this particular drug and whether it can be used or judicious use. That was a big controversy all over the world and for Indian physicians also. We have the data to suggest that in 2016 British Medical Journal to show that the patients who are more than 1,45,000 patients duly treated with an anti-diabetic drug, and they had shown, and this particular study, the result of this large population-based study indicate that pioglitazone is associated with increased risk of bladder cancer, and this was one of the reasons that it was made for many of the countries before that, and this was in 2016. But simultaneously, there was one more registry which had come before in 2012 that had shown 8-year incidence of bladder cancer analysis with KPNC registry, which had shown rather with treated patient it was less cancer, and those who have never received the pioglitazone were found to have more bladder cancer. So this is a big controversy, and one data is showing there is increased cancer incidence while other data is showing a more from the almost cohort study. The pioglitazone reduces cardiovascular events. This was a proactive trial which had shown the CV outcome was better. Rather, there was a recently paper with Defonso in 2016 which had shown that the benefit of pioglitazone, sorry that this you can't read, that it can significantly decrease either MI or stroke. In the proactive study, pioglitazone decreased the mass endpoint by a similar degree that was observed in MPARA study. So I mean, you can compare that pioglitazone was in other study had shown, and this was a recently paper after proactive in 2016 which had shown that it can reduce similar amount of reduction in cardiovascular issues like what empiric outcome data was there. So this confusion was there for all the physicians whether they should use it, whether they should not use it. But the current FDA standpoint is showing that the patient there is insufficient data to determine whether pioglitazone is a tumor promoter. Pioglitazone should not be used in patients with active bladder cancer or history of bladder cancer. And if it is to be used in your patient, I mean again it is left to the doctors or to the physicians that whether they want to use for their patients on which particular clinical condition they should use or they should not use. They have to decide on their own. The uses of alpha glucosidase inhibitor. In India we are using very high, but it is always an issue for its efficacy because it is a drug which is considered a weak drug for its efficacy. And in American Diabetes Association guideline it is never part of the algorithm, and that's the result. And GI upset is also a major side effect, and because it's less efficacy, it is found that the reason ADA had not put in the part of its in the algorithm guideline also. But for the reducing glycemic variability, it is significantly higher, particularly in Indian subset or the Chinese patients where they are consuming high amount of the carbohydrate. If you see the efficacy of ADA, this paper which has shown equally efficacious in compared to other molecules also. At the same time, the comparative efficacy when it was compared with the newer drug also, it was shown to a good efficacious drug. And there was one more trial from a globe and data from India where we had shown even with the patients with the baseline HbA1c higher, the significant HbA1c reduction was there in the patients who were using the acarbose and metformin also. There is a greater contribution of postprandial hyperglycemia, as we know that. We all know about the earlier slide that when your HbA1c is higher than 8.5, it is the fasting which is contributing more. But for Indian patient, it is at any level of HbA1c, you know that fasting and postprandial both are always a problem. So I mean, you have a patient with 9.5 also, you have to treat fasting and postprandial both simultaneously, and that's the reason. In Indian uses, the AGI uses is very high, but still there is a lot of controversy. One very important controversy regarding the use of AGI is that in India we are using a triple drug combination with AGI used along with metformin and sulfonylurea. No clinical data, but still it is used very high, and that's a very important controversial issue whether to use this mixed drug combination or not. Then we know that higher glycemic response is responsible for Indian patients to have more BPC, and that may be one of the reasons to use it more in alpha glucosidase inhibitor in the Indian patients. But we don't have a long-term data from India. Now we will be having during ESD the economic cardiovascular outcome data will come from China, and that will be a big study as far as Asia is concerned. But in my clinical practice, I have seen the patients, and this I am willing to insulin. If you see that ADA guideline or even case, we will talk about the first line, second line, third line. Nobody talks about the fourth or fifth, whether to be given or not. It's always controversy. Is fourth or fifth drug to be used? How much it is efficacious? Even if it is to be used, will it decrease the HbA1c? Will you able to achieve the HbA1c less than 7? We don't have the data. In how many percentage of patients will be able to get the glycemic control? And more important, how long we can continue the therapy? I mean, how much durability point of view? So suppose you started a patient on a fourth or fifth drug, will you able to achieve the HbA1c control after 3 months, 6 months, 9 months, 12 months? We don't have a trial. And can be used because particularly in Indian setting, which I am talking again, like use of AGI and SGLT2, theoretically it can be used because if somebody is already on a triple drug and if you want to use these, the mechanism of action of AGI and SGLT2 is purely insulin independent, and why not they can be used? So why not we can't use the fourth and fifth drug? And many of us are using also, and we see that data, but we don't have neither a prospective or retrospective data to show that it can be useful. I just give you a clinical scenario when many of our patients on a triple drug therapy, either on metformin, sulfonylurea, diazepam, or metformin, sulfonylurea, 15. Suppose the patient HbA1c is between 7.5 to 8.5. What will you do? Will you start the patient on insulin because patient is under control, or a triple drug therapy, almost maximal dose of the oral antidiabetic agent, or can we add in this particular situation a fourth or a fifth drug which is alpha glucosidase inhibitor or SGLT2? We don't have the data. Main problem is we may have the patients whose HbA1c may control within 3 months, whatever the which we add on fourth or fifth drug, but how much durable it is. Whether patient will achieve the same amount of glucose control after 6 months, 1 year and 2 years, we don't have the data. So in real clinical practice, we use it, but we don't have a clinical trial data to support of use of fourth and fifth drug, and that really confuses many of our clinicians. Some data are coming. Recently, some papers were there that delaying insulin therapy with SGLT2 as a fourth oral hypoglycemic agent in type 2 diabetic patients, and then they all have retrospective data for that. Now, the use of insulin at the time of diagnosis. There are some papers from Korea, China, even from India also, Gilmore and group. They had suggested there are little data because they had used only a very small number of patients. As soon as somebody is diagnosed with diabetes, instead of giving him any other therapy, a type 2 diabetic patient use insulin for a short period of time. Try to reduce the glucose toxicity and get remission. In some of the patients, they had shown that some of the patients had gone for a remission, and these were the type 2. I am not talking about the patients who are LADA or who are slow type 1 or type 1 diabetic patients. And then these are the data to show that use of insulin at the time of diagnosis. And these data also confuses physicians. Many of the time, primary care physicians, they feel that because somewhere they read that insulin should be used at the time of diagnosis itself. We may not have sufficient data, but they started using also. And sometimes patient may have benefit, sometimes they may not get the benefit also. The hypothesis is that early insulin therapy will preserve the beta cell, and the early insulin replacement, the resting the beta cell, and this sustained adequate glycemic control maybe for longer period of time. They had seen almost a median period of 26 months. So they are saying that remission is there for another 1 or 2 years, and this they are thinking of a diabetes prevention. Somebody has full-blown diabetes and now going in remission by using the early initiation of insulin. Not early initiation, you say at the time of diagnosis itself, the insulin was started. So this is the one paper where they had talked about the insulin should be prescribed at the outset of the diagnosis of type 2 diabetes itself. Now, before that, I was just listing the way to start insulin and how it should be further intensified. And it is always a confusion at what level of HbA1c and at how many OAD we should start the insulin. It is a like uncontrolled diabetes. Uncontrolled diabetes means somebody is on 3 drugs and HbA1c is 7.5. It's an uncontrolled. Somebody is on 5 drugs and HbA1c is 7.2. It is uncontrolled. Or somebody is having already hypoglycemia but HbA1c is 8. He is already getting weakened hypoglycemia because of sulfonylurea. HbA1c is 8. Whether patient should be started on insulin or not, that's always a confusing issue for the doctor. Whether they should start with basal or they should start with premix, because there is a premix guideline also available in our country, which is been published first time in 2008, then again republished in 2013, and again now going to come is a premix guideline for Indian patient. How to intensify? Whether we should start with the basal and then intensify premix insulin and basal insulin which should be started. There are meta-analyses which show that long-acting insulin analog are better control fasting over the premix insulin, but at the same time, the similar data are there with premix insulin for better control of HbA1c also, because we have the premix insulin will better control the fasting and postprandial both, but at the same time, there is one more slide for the premix. I'm sorry for that. The premix insulin decreases the HbA1c better, but there was more incidence of hypoglycemia also at the same time. And even if we have more data for the longer acting to control the fasting, to fixing the fasting first, that's an idea. But still, 70% of our diabetic patients in the Indian situation, they are still on premix insulin, and it is the biggest molecule of our country. Even from all in medicine, the premix insulin is the highest selling molecule in the country. This is very important in place of GLP-1, where they should use. In Indian patients, we are not very much, we are not using very high amount of the GLP-1, but still, it should be started first injectable therapy for type 2 diabetes. It should be started after insulin therapy with the basal insulin. For an intensification, should we use GLP-1, or we should start the patient simultaneously, because now you have a combination in a co-formulation where GLP-1 and basal insulin is combined. So that is not clear, but I will not go in detail because there is a debate where GLP-1 or against the SGLT2 after the metformin therapy, so we will get more data about it. But that's always a confusion, because some data are showing the GLP-1 should be the first injectable therapy for a diabetes type 2 diabetic patient. It means it is after 3 drugs or 4 drugs, the GLP-1 you are giving, but that's not in guideline. And whether it should be after the basal insulin, because in guideline it is shown that before intensifying the patients for a basal plus and basal molar, you should use the GLP-1 for these patients. Then there is one more controversial issue about the use of bioimpedance and sulfonylurea with insulin therapy. Suppose you are already having a patient who is on basal insulin or basal bolus or basal plus, should we stop the bioimpedance? Because we had seen when you combine or continue the bioimpedance and then add on insulin, there is an increased weight gain, and very high amount of weight gain is there, and even the fluid retention is also high. But at the same time, if we stop the bioimpedance, there is a rebound hyperglycemia. Even more amount of insulin is required, because we are stopping a very important insulin sensitizer, and that's a very, very important debatable issue always, whether we should stop or we should not use. The similar way for the sulfonylurea. Should we stop sulfonylurea when you are using a premix insulin? Like if you are starting a patient with a basal insulin, that's fine. But if you are using a patient on a premix insulin to start with, should we stop sulfonylurea or not? That's a very, very important and debatable issue, because we have seen sometimes when you stop the sulfonylurea and you use the premix or basal bolus or basal plus, the requirement of insulin is very, very high, and some of the patients even sugar is not controlled. So no guideline is talking about whether we use sulfonylurea with premix or without premix. Last part, then oral hypoglycemic agent to be used in GDM or not. If diet and exercise do not lead to adequate glycemic control in women with GDM, then insulin should be given. Now this is the recommendation. Oral hypoglycemic drug, particularly sulfonylurea, are contraindicated during pregnancy. This is what we have. The consideration for use of OAD in pregnancy, it should not produce the risk of maternal as well as neonatal hypoglycemia. Last slide on. The rationale for use of oral anti-diabetic drug is that underlying principle for the use of OAD in pregnancy is motivated by following factors, that GDM and IDEC are characterized by mild hyperglycemia. So it is reasonable to assume that treatment of GDM with OAD should be as effective as they correct the pathogenesis of hyperglycemia. It is because of insulin resistance. The management of GDM, recent evidence has prompted to relook at the role of some of these agents in pregnancy, and these 3 agents are classified as FDA category B, which is metformin and then ACI also, and sulfonylurea, because there are some plans to implement combined. But in India, after this big trial, we started using metformin in many of our patients with GDM, and this big trial which was compared with insulin in GDM patients, and where metformin is not associated with increased perinatal complication as compared to insulin, and this has shown that metformin can safely use in the patient with GDM. Metformin in gestational diabetes was the offspring follow-up also. So mid-toxin body composition at 2 years of age, and which has shown that those patients who had participated in mid trials were reviewed, their children were 2 years old, and body composition was measured in 154 out of 164 children whose mother had been randomized to metformin. And what had they shown? The children were assessed with anthropometric difficult, very complex. Multiple data are there, and we are getting more and more data every day on different aspects of diabetes therapy. So we get more and more controversy, and that is obvious. So there cannot be a blanket therapy for all patients. You cannot have whatever which we are studying, whatever we have in the trial, you cannot use it in blanket therapy for our patients. We have to have an individualized approach for our patients who is sitting next to you, and we have to take it a personalized medicine for the patient. The physician must do a